Oh, we're getting all sorts of participants. Perfect.
Okay.
Working?
Okay. No, I want attendees. Just give us a few minutes. We're having some technical difficulties. Dr. Kahn's session would not open up in Zoom, and we need to get the doctors into this session. So if you could just give us a few minutes to get this situated, we apologize. No, mute us. Yes.
All right, sorry, everybody, for that difficulty. For some reason, we lost the Zoom link with the event website. So we're just gonna merge these two together.
Go back.
But we're got a video that Dr. Kahn recorded yesterday that we're gonna go ahead and play. It's about 28 minutes, and then Dr. Schoback will be doing the Q&A for that as well. So we get to hear from her yet again. So with that, I'll go ahead and get that set up and get that started.
Replacement therapy in hypoparathyroidism. If you can see my slides, these are my disclosures. I have received research funding for the development of new PTH molecules and also for the treatment of rare metabolic bone diseases and osteoporosis. So as I explained previously, we know that the calcium sensing receptor in the parathyroid glands senses calcium. And when calcium levels are low, it's sensed by the calcium sensing receptor, and it will increase the synthesis and secretion of PTH from the parathyroid glands. And then what PTH does is it enhances the ability of our kidney to reabsorb calcium. So calcium reabsorption through the kidney is enhanced. And so every day we filter 10 grams of calcium, and 9.8 grams of calcium are reabsorbed. And in the presence of PTH, we're able to maximize calcium reabsorption. If we don't have PTH, then we will have a leak of calcium through the kidney. The other effects of PTH are bone resorption. So PTH will act on the PTH receptors and cause osteoclasts to become active. It actually works on the osteoblasts, which then signal to the osteoclast to start removing bone. And the osteoclast can drill out calcium and phosphate from the skeleton, and calcium and phosphate enters the bloodstream, and it will help to bring that calcium back up. And PTH, when it was reabsorbing calcium through the kidney, it gets rid of phosphate. So it has a phosphaturic effect. And it's important to have that because we don't want phosphate levels to be high. We want to make sure that our calcium is normal and phosphate should be normal. If phosphate is high, that's a problem because it causes ectopic calcification. It can contribute to calcification in the brain, calcium deposits in the eyes. It can cause calcium deposits in the kidneys and damage our kidneys. And the other effect of PTH is to take 25 hydroxyvitamin D and form active 125D, 125 dihydroxyvitamin D, which is calcitriol. And calcitriol helps to maximize absorption of calcium and phosphate from the bowel, and it gets calcium and phosphate out of the bone. And so through these mechanisms, PTH is able to reestablish the calcium level. It maintains normal serum calcium and normal phosphate. Now, if we don't have parathyroid gland functioning, if our parathyroid glands are damaged or they've been removed, or there's a resistance to PTH, then we don't have the benefits of the effects of PTH. And we've talked about how we can replace the loss of PTH by giving calcium, give back active vitamin D, but we don't correct the phosphate loss. We don't correct the phosphate that is high in the absence of PTH, and we don't correct the high urine calcium losses in the absence of PTH. So giving back PTH would make the best treatment sense because we'd be giving back the missing hormone. So what I'm going to talk about today is what is the research looking at? Where are we today in being able to give back PTH? So as I've mentioned, someone who doesn't have PTH is going to have a low serum calcium. They're going to have a low or inappropriately normal PTH. They're going to have a high phosphate because they haven't been able to get rid of it through the kidney. They're going to have a high urine calcium because they can't reabsorb the calcium through the kidney. And they're going to have a low 125D. And that's why we have to give them something, either active vitamin D or give back the PTH. But in the absence of PTH, if we just gave back calcium and active vitamin D, what would happen is the active vitamin D increases the absorption of calcium and phosphate. So there further rises in phosphate. It increases the risk of calcium and phosphate deposition in the kidney and contributes to renal failure. It increases urine calcium further, and it can also result in wide fluctuations in serum calcium. And so there are limitations to conventional therapy. And I describe this to my patients by saying they're on the calcium roller coaster. Their calcium could be high if they're taking too many supplements. And then when it goes down because of exercise or for whatever reason, the calcium levels are low, they end up in hospital, they get more calcium and active vitamin D, they might overshoot. So they're up and down, up and down. And that's a problem. And it's associated with significant complications. So our goals of therapy are to correct the serum calcium, keep it in the low normal range, correct the phosphate, and correct the urine calcium, and avoid calcium deposits in the kidneys and in the brain, in the eye, in places that it is not supposed to be depositing. So what are the PTH formulations that we have available to us? Well, we have PTH 1 to 34, and the half-life of this molecule is about an hour. And so it requires multiple injections per day. So we have people who have used PTH 1 to 34, 20 micrograms twice a day is a useful approach to replacing the PTH that is missing in hypoparathyroidism. Then we have recombinant human PTH, 1 to 84. Half-life is longer. From 1 hour, it's gone to 3 hours. And it can be given as a once-a-day injection because it has a longer half-life. And some people only need 25 micrograms. Some people need 50. Some people need 75. Some people need 100. So we need to gradually titrate so that the patient's calcium will be normal and the phosphate will be reduced, and hopefully the urine calcium will go down. The latest molecule that is a PTH molecule that is being evaluated right now in phase 3 trial, so that's the last phase of clinical research, is a kahn PTH. And this has a half-life of 60 hours. So it results in a stable level of PTH throughout the day. And I will be presenting that data to you as well. So with 1 to 34, what is the research showing us? Well, 1 to 34 can normalize calcium. It can reduce the need for calcium and active vitamin D. It can decrease the urine calcium, and it can increase bone remodeling. So it can allow us to access the calcium from the skeleton. And it has been shown by Andrea Palermo and colleagues that it can improve the quality of life in an open label 24-month trial when it's given twice a day. What is the long-term data with the PTH 1 to 84? Well, this molecule has a longer half-life, and this has been studied, the long-term data that was published out to 8 years in 24 patients. We have safety data published in 2019, looking at various preparations, a 25, 50, 100 microgram dose. And calcium and vitamin D requirements were reduced, and serum calcium remained. And the urine calcium decreased by 38%. And what happened to bone density? Well, the bone density actually increased a little bit at the spine, and it was stable at the hip, and at the arm site, it went down. So those were the results of long-term PTH 1 to 84. And clearly it's a value because it's going to improve the patient profile, the lab profile is improving, and it is going to be able to reduce the requirements of calcium and active vitamin D. The need for the huge doses will be reduced. And in this study, the urine calcium did decrease, which is a good thing. In the replace study, this was looking at PTH 1 to 84, and it was comparing 1 to 84 with conventional therapy. So calcium and active vitamin D, there were 134 patients randomized, and the dose titration, you begin at 50 and then gradually go up. And patients were compared to PTH versus calcium and calcitriol or alpha calcidol. And what was looked at was how many people are able to reduce their calcium and active vitamin D by more than or 50%, by equal to or 50% or more reductions in the dose of their supplement. And the secondary endpoints were ability to stop them completely while maintaining serum calcium. Okay, so let me show you the data. So there was an initial optimization phase, titration phase, and a maintenance phase. And the response was how many people were able to stop their calcium by 50% or more, and stop the vitamin D by 50% or more, and maintain a normal serum calcium. So what was the answer? Well, what was seen at week 24 was 53% of people who were taking the recombinant human PTH were able to achieve that goal. And placebo, it was minimal. So placebo meant the calcium and active vitamin D supplement arm. So clearly this medication is able to help our patients come off calcium and active vitamin D. And we can see that how many people were able to stop vitamin D and have a calcium dose that was less than 500 or 500 milligrams a day. And 43% of people were able to do that, totally stop their active vitamin D. And here you can see that there's the PTH group and there's the placebo group. In the PTH group, calcium levels were nice and stable. And in the conventional therapy group, there's some drops here as we're trying to get them stabilized with the study medication, and then the calcium levels stabilized. And the urine calcium did go down in the placebo group, which was the active vitamin D group, as well as the PTH group. And the phosphate levels dramatically declined. So this is a big, big plus. We don't want our patients to have a high phosphate. So with recombinant human PTH, we were able to drop the phosphate levels, and that's a big plus. And what happened to the rate of bone remodeling and repair? So what was seen were these biomarkers that are a reflection of the function of the bone cells. How well are the cells that remove bone working? How well are the cells that form bone working? And we can see that they're definitely working more actively. And if we look at the bone density, we can see that at the spine and the arm, there was actually no difference in bone density, but there were small decreases seen at the total hip site and decreases seen at the femoral neck. And this is a sign that the bone is normalizing. It's recovering its ability to repair and renew itself. And the thick, high density bone is becoming closer to normal. The PTH was well tolerated. The adverse events were similar to placebo, and the adverse events were reflective of the underlying disease, hypoparathyroidism. It's associated with numbness and tingling and muscle spasms, headache and hypocalcemia, and the discontinuation rate was lower in the recombinant human PTH group. It was 7%, whereas in the placebo group, it was 16%. So fewer people stopped the PTH in comparison to the placebo. So it was well tolerated and it was an effective medication. So from the REPLACE study, we saw that it was able to reduce active vitamin D and calcium. It decreased phosphate. There were fewer symptoms of hypocalcemia. It was normalizing the bone remodeling and repair, and appears to be a valuable
Sorry, everybody, we'll resume the video in just a second. What is that video again?
So from the replace study, we saw that it was able to reduce active vitamin D and calcium. It decreased phosphate. There were fewer symptoms of hypocalcemia. It was normalizing the bone remodeling and repair, and appears to be a valuable treatment strategy, and it may reduce the long-term complications of hypoparathyroidism. So the FDA actually approved this drug for hypoparathyroidism in 2015. Unfortunately, there was a recall in 2019 because of foreign particles in solution, and this is currently being addressed right now. Okay, let's move on now to the third PTH molecule, which is the trans-kahn PTH. And these are the slides that we just recently presented. I presented these at the ASBMR meeting in October. So what is trans-kahn PTH? Well, trans-kahn PTH is basically PTH 1 to 34. There it is. It's depicted by this little orange squiggly line, and it's linked to a polyethylene glycol molecule that surrounds the PTH, and then it's injected. So it's injected, and when it goes into our skin, underneath the skin, when it's exposed to physiologic pH and temperature, the linker cleaves and it releases the PTH, which can then go and bind to its receptor, and the linker and the polyethylene glycol is just cleared through the kidney. And by giving it as with this linker and this polyethylene glycol, we can allow that PTH to not have just a 1 hour half-life or a half-hour half-life, but to extend that half-life. So out to 60 hours. So if you look over here, when we're talking about half-life, the half-life of PTH 1 to 34 is 1 hour. But trans-kahn PTH has a 60-hour half-life. How are we able to extend it? It's because we've linked it to this protein that allows us to extend the half-life of that molecule. So this results in stable PTH levels. And that's what we saw when we did the research and measured free PTH, that's PTH 1 to 33 and 1 to 34, we saw that the levels in the blood were stable. And so the phase 2 trial looked at trans-kahn PTH 15 micrograms or 18 micrograms or 21 micrograms a day in comparison to placebo over 4 weeks. And then there was titration of the trans-kahn PTH and standard of care with a goal to keep the calcium normal. And the doses of trans-kahn PTH that were used were 6 to 60 micrograms a day. And the primary composite endpoint at week 4, we wanted to know, well, how many people were able to keep a calcium level that was normal and stop active vitamin D, and were able to take less than 1 gram of calcium a day and had a normal urine calcium or a 50% or greater reduction in urine calcium. And then at week 58, and this is the data that I'm presenting to you now, how many people were able to reduce their supplements and look to see what was happening at the urine calcium, serum calcium, phosphate, and the calcium phosphate product, and also the quality of life. So we looked at that as well. And so these are the people that we evaluated. In total, there were 59 patients. As you can see, most of them were between the age of 30 and 65. A majority were female, majority were Caucasian, and this study was largely recruiting from North America and Europe. And most of them had hypoparathyroidism following neck surgery. A much smaller percentage did not have it after surgery, and they were taking calcium, calcitriol, and alpha calcidol. Okay, so what happened at week 58? So if we look here at week 58, well, basically, how many people were able to stop active vitamin D? Everybody. Everybody was able to stop active vitamin D. One person dropped out, by the way. So that's why, and it was for a personal reason. It had nothing to do with the study. But because of that, we had 58 subjects achieving the key time point. But everybody was able to stop active vitamin D. How many people were taking less than 500 milligrams of calcium? Well, 90% were down to less than 500 milligrams of calcium. How many people were able to stop their vitamin D and only take 500 milligrams or less of calcium? 90%. And how many people were totally off calcium and vitamin D? 69%, close to 70. So that's really great. You're able to come off these supplements. As you can see, there was a dramatic reduction in the calcium dose that was required. This is the group that was on placebo, and when they went on therapy, we were able to stop their calcium and their active vitamin D. And here's the calcium. You can see it's being maintained in the normal reference range at week 58. Here's the urine calcium. Look, at baseline, it was high. And with therapy, it was reduced. It went down by week 26 and a further statistically significant reduction at week 58. And what happened to phosphate? Well, phosphate levels dropped and the calcium phosphate product went down with this molecule. And that's really great news, because that's what we want to do. We want to drop the phosphate. We want to drop the calcium phosphate product. What about the biomarkers? Well, we did see rises in the biomarkers, and we're seeing that they are normalizing. The biomarkers were normalizing, and the bone density at baseline was also starting to normalize. And so it slightly decreased at the lumbar spine, because in people with hypoparathyroidism, the bone density is higher than what we would see in someone who has normal parathyroid function. And so it's starting to normalize, and then it's stabilized. And we can see that is happening at the femoral neck, the hip, and at the arm. There was no change in the bone density. What about the effect on quality of life? Well, we can see over here, their quality of life scale, SF36, there's a physical component, and this is where the normal population is. And at baseline, people with hypoparathyroidism have poor quality of life. And we can see that their scores were less than the normal patient population. But with therapy at week 58, the quality of life improved and they reached the normal population. That was in terms of the physical component. What about the mental component? Did that improve? Well, look at this. The mental component also improved at week 58. And over here, you can see at baseline, they weren't feeling as well, because the greater your score, the better you're feeling. So they're feeling pretty poor at the beginning. But the blue is week 58. And by taking this medicine, they were feeling better and better. And our patients told us that, our patients, one patient was crying. She was a nurse, and she told me, Dr. Kahn, you gave me my life back. And she was, flying up from Ottawa. And she was really emotional to see the impact that this medicine was able to make in her life. And she was really suffering after developing hypoparathyroidism. She was suffering because of the severely negative impact this had on her quality of life. But starting this medication, she said, I was able to get my life back. Another one of our patients, he had very poor quality of life before. His calcium was either high or low. He was always in hospital. Every time he was supposed to see us, he couldn't come because he was in hospital. Either his calcium was high or his calcium was low. But eventually he did come. We put him onto the medication, and he felt so well that he started to go into construction and do heavy, heavy physical work. As a construction worker, he began to build his own house. And he's coming in now with a big smile on his face, and he looks and feels great. And other people, they've gone back to school, they've gone back to work, they're feeling tremendous improvements in their quality of life. their cognition, their energy. Another patient was able to stop her depression medication. And she said, I was able to stop my antidepressants after treating the hypoparathyroidism. So hypoparathyroidism has an impact on the brain. It has an impact on muscle mass. It has an impact on muscle function. It has an impact on our overall well-being, on anxiety, on mood. And we're seeing an impact with pharmacologic intervention. Now, this scale, the hypoparathyroidism patient experience scale, is seeing how many symptoms do you have of hypoparathyroidism. So the more symptoms you have, the worse you're feeling. How much numbness and tingling and muscle cramping are you having? How is your brain fog? And at baseline, the patients are feeling pretty poor. But at week 58, they were feeling much, much better. So the symptoms of hypoparathyroidism had dramatically improved. And this had an impact on daily life, physical function, psychological well-being, social life, and relationships. So it has an impact. And what about side effects? Were people having to drop out of the trial because of side effects? Well, the drug itself did not cause any serious treatment-related adverse events. There were none. And no patient stopped the study because of the side effects of the drug, and no patient died in the study because actually there were no deaths, but nobody had any treatment-related adverse events. So the conclusions from the Path Forward study were that with this molecule, using this polyethylene glycol to extend the half-life of PTH, we were able to achieve stable PTH results and maintain a normal serum calcium, reduce phosphate, reduce the calcium phosphate product, and reduce the calcium excretion through the kidney, and improve the quality of life. And bone remodeling improved. And the TransCon PTH is doing very well. And we still have, we have 58 subjects in the trial. As I mentioned, one person did drop out. So the conclusions are, PTH replacement therapy is a very valuable approach in the management of hypoparathyroidism. We're finally able to give back the missing hormone. And we need to look at the research and do more studies to see if by giving back the missing hormone, can we improve the quality of life and reduce the risk of complications? What about the impact on cataracts? That was a question that was asked. Can we prevent cataracts by normalizing phosphate and by normalizing the calcium phosphate product and by normalizing serum calcium? Can we prevent the basal ganglia calcification? Can we prevent kidney calcification? Can we prevent the decline in kidney function that happens with hypoparathyroidism? Well, to answer those questions, we need longer and larger studies to document the impact on the long-term complications of hypoparathyroidism. But I'd like to thank you for your attention, and would be happy to answer any questions that you have. Thank you.
Okay, thank you, everybody. Dr. Schobach and Dr. Kohlmeyer.
Yeah, we only have a couple minutes because of the difficulties. We only have a couple minutes for a few questions, but there wasn't a whole lot of questions in the chat, a lot of good comments. But we'll ask a few questions and then we'll get ready we'll just stay in this session for Dr. Kohlmeyer's. After that, we'll probably take 5 minutes before you get started, Dr. Kohlmeyer, if that's fine, after we get done with the Q&A.
Okay, there's a question. Can calcium deposits be found in lungs, veins, cardiovascular at an increased rate for parathyroid patients?
Go ahead, Lynn.
Absolutely. And thank you, everybody. This has been such a fantastic conference. Yes, I think that we're concerned about that. And that's one of the main reasons we try to keep serum calcium really in the low normal range when patients aren't on parathyroid hormone, and we, look for renal calcifications and calcium in other areas. Dr. Schoback, do you want to add to that?
No, I agree. That's what we're trying to do with the balancing of the different medications. We're really trying to get everything as normal as possible so we avoid those calcifications. I would say, like Lynn said, the cataracts, the brain, sometimes the kidneys. I haven't seen it in the lung so much or the heart, but it would depend how high the numbers are.
And Dr. Clark's going to talk about that tomorrow as well.
Okay. Did the study of patients have daily fluctuations in a 24-hour period? Or in other words, do they feel the symptoms on and off during the day when on PTH therapy?
Well, to my knowledge, I don't think anybody's done exactly what that questioner is asking, kind of looked at symptoms and 24-hour calcium. That would be a great study, but I don't think it's been done on any of the trials.
I agree. And I think that's why we're hoping there'll be, a finger stick calcium test, like a blood sugar, so that when you're having symptoms, you could know your calcium right away. And I think that one of the reasons I'm so looking forward to presenting my patients next is to illustrate how the symptoms don't always align with calcium levels. And is that a muscular neurosensitivity? What is that? And a lot of you already asked those good questions. And I wish there were studies looking at that, and we need some.
Okay, this is a very good question. If the half-life is 60 hours on TransCon, why is it still dosed every day and not every other day? And is that being evaluated?
Yeah, to my knowledge, it's not being evaluated every other day, but you do make a good point. I think the idea is to have the level be as smooth as possible so that there aren't ups and downs in it. And so the half-life is long so that if you miss a day or whatever, you're probably protected, which is nice, certainly. Not that we want people to be missing medications that are important, but certainly there's a little bit of, protection there. Maybe as we get more information, different dosing schedules can be set up that'll work. But right now it's being evaluated as a once daily injection.
And I asked that exact question to Ascendis and to the other companies making parathyroid hormone, because a once a week injection would be so much more convenient, or even twice a week. So it's a good point.
Okay, so the next one says, if the TransCon phase 3 studies show the same results as phase 2, what are the chances of asking for the trial to end and the drug to be approved on fast track?
Well, none of us can really gaze in a crystal ball on that. It's of course up to the FDA, but I do know that because hypopara is a rare disease, there is the possibility of the fast track. And we would probably need to ask our pharma colleagues exactly what that means when they get the entire file prepared and submit it. They will have the ability, I think, to do some kind of rapid review, but it's COVID as well. And I just don't know. I wouldn't want to promise anything.
And I think what we've learned during this difficult time with COVID is that some things can be fast tracked. And could we ask for emergency use, or is there other way around it so we don't have to wait that 6 months? So it's a great point.
Okay, someone wants to know, can the serum calcium level be kept higher than low normal range when on PTH therapy, if that's where one feels best?
That's one of the great things about it. I think that if you look at all those lab parameters and you have a good serum calcium right in the middle of the normal range and the urine's okay, I think you can go with it. So I think that's what we're all hoping. That's what I'm hoping. What about you, Lynn?
Absolutely. It all depends on your urine calcium. So if you weren't spilling a lot of calcium, or you just, are lucky enough to have a low salt diet and it works for you and that helps lower your urine calcium, and you haven't had any kidney issues, we're always much more comfortable bringing the calcium level up, especially on PTH. And maybe that's what the nerves and the muscles need for you to feel like you would if you never had hypopara.
Okay, and it looks like we have one final question that actually like 6 people asked this question. Can you guys address not just for TransCon, but for all the PTH drugs, including someone mentioned Forteo, about the risk of the bone cancer, because it's listed on all the PTH drugs that they're at risk for bone cancer. So can you address that?
Well, I would say that, first of all, the label on Forteo does not have the osteosarcoma risk. Forteo as indicated for osteoporosis. So the 2 years of Forteo, they didn't see any osteosarcomas in the humans that were receiving it for osteoporosis. Nothing over the rate of osteosarcoma in the general population. I look at it as if you're taking PTH as a replacement, you don't even have your own. So I think of it as a lower risk. But I don't know what the FDA is going to say, because I think we are talking about the use of PTH lifelong, kind of like lifelong replacement. And we don't have data for anybody's lifelong anything. So I think we might see a label that might have that on there. But I guess I feel reassured by the couple million patients who've received it for 2 years for osteoporosis and didn't see it. But that's my opinion.
Well, thank you very much. Dr. Schoback, we like to extend an extra thank you to you for hanging out with us for like 3 hours today and
Thanks,
sitting
Pat.
through all the technical difficulties. We really appreciate your expert advice. You've been great. Dr. Kohlmeyer, we're going to take a 5-minute break. Don't log off, just kind of stay there, put it in pause, and we'll check back in with you when you're ready, okay?
I'll be here. Thank you.
Bye.